I'm really delighted to be here and welcome this opportunity to come to Rochester, Minnesota. I just got back from Mexico. I've been working with the Mexican government for a number of years, and they put in a program to insure 50 million Mexicans. It's called Seguro Popular. It started 12 years ago, and they're celebrating the 10th year anniversary, couple of year preparation. And I was down in Chiapas, where I've gone for a number of years to do a survey with physicians from around the world that they bring in to evaluate their healthcare system. So their problem was, we've got 100 million people in our country, and 50 million have zero access to any kind of meaningful delivery system. In 10 years, they put in a meaningful system. It was a remarkable several weeks that I spent down there. What I'd like to do is shift here to talk to you about a lot of the themes that the other speakers have discussed, but I want to use a little different framework. I want to use an example that happened in New York City 11 months ago, almost a year ago, of a hurricane that devastated the 3 hospitals that I've been intimately involved in for nearly 20 years, and talk about some of the factors, some of the risk factors, some of the issues that are latent within our systems that we really can't see until something happens. And the title of my talk is Seeing in the Dark. At the end of October of last year, a transformer blew on 14th Street on the east side of Manhattan, and all of southern Manhattan, south of 34th Street, was completely blacked out. There were no telecommunications, there was zero electricity, no water, et cetera, and Hurricane Sandy had hit the city with a 15-foot surge. I want to talk about the healthcare implications and some of the contextual implications of that event. So Hurricane Sandy was ambling along at about 4 or 5 miles an hour for some time before it hit New York City. There was a tremendous discussion about the implications of a hurricane and a surge and what would happen to New York City. New York City had been preparing for a surge for 15 years. There had been at least a dozen reports from the Goddard Space Center, which is the leading national entity that looks at the effects of anthropogenic global weather changes and its effect on our societies, to many, many local expert groups that had all said what the risk was to New York City if a hurricane of the magnitude of Sandy hit. There were organizational responses, which I want to get into in a few minutes, that were very, very different within the organizations that I work with. The 3 hospital organizations all had completely different responses to this event. The perceived risk were very, very different depending upon which facility you were associated with. The responses were different, and the narratives after the event were very, very different. This is my one slide just to relate to the other 2 speakers. What is the big issue here? The big issue we're dealing with is healthcare cost structure is unsustainable for us to take care of patients with the current delivery system model we have. The delivery system model is what we're talking about that needs to be transformed in a very deep, profound, fundamental way. And one of the issues that's going to be a recurring theme in my short presentation is the factors resisting the change to a different kind of environment. You've heard from some speakers who are really at the cutting edge of where we need to be. From the federal bank, where we need to be, what their idea of policies are and how to break down the barriers, and from a healthcare provider system. So the key issue that you've heard put on the table here already in very, very detailed, articulate way, that's a foundational question. Does healthcare equal health? And as you saw from the slides that have already been presented, it equals health to a certain percent. Now, if you're in another country and you don't have access to healthcare, you're desperate to get healthcare. But healthcare is much more than the delivery system. We've been wrapped around a conversation about the delivery system. There are thousands and thousands of books about the delivery system. There's an entire class of punditry that just comments about the delivery system. It is approaching $3 trillion. We already know that the delivery system does not equal health. It's necessary, but it's not a sufficient component to have a healthy society. My own trajectory, my own story began back in the early 1980s when I worked at a hospital in the Central Valley in Haiti, the Albert Schweitzer Hospital, in a town called Deschapelles. And we started seeing patients who had new symptoms with uncontrolled tuberculosis. They were losing weight and they had skin lesions. We knew something was different. We had a lot of patients with malnutrition, diagnosis of marasmus and kwashiorkor. These patients were dying from lack of food. In fact, our number one item that we wrote out from our pharmacy at the hospital Albert Schweitzer was a prescription for food for our patients. So the AIDS epidemic was beginning and we started to see it. We didn't have a name for it yet. It was before it even got identified, the virus was identified. And now 30 years later, AIDS has been turned into a chronic disease. But I just want to point out, it's been turned into a chronic disease, one, because of tremendous scientific advances, extraordinary scientific advances, but two, because of the social and political and economic impacts of patients and support groups that made the drugs available widely throughout the United States. And now the next phase is on to a global extension of the scientific breakthroughs to other societies. We see this repeatedly. We have the treatment, but we can't treat the disease. We can't get to the patients for a variety of different reasons. So our current healthcare organization model is decision-making is in a very, very risky environment. If you're a healthcare CEO or on the executive team, it doesn't matter where you sit in the system. You could be the Northwestern system, the Mayo system, San Francisco, Columbia Presbyterian in New York, the top systems in the country. It is extremely risky. It is not clear where your margins are going to be a year from now. And putting bets on some of the things we're talking about even make it riskier. That's one of the reasons why this is a very, very difficult decision and decisions to make. Even if you're a smart guy, you're sitting in your office, smart woman, you're saying, what should I do about this situation? The financial risk is extraordinary. So are you on the right road? And how do you know you're on the right road? There are not clear signals. There's a lot of noise, but there are not clear signals for executives in this situation. So Sandy, to me, is a little bit like the Herman Melville story. It's the whale. It's the healthcare system. We see this disaster coming down 4 or 5 miles an hour. We have plenty of time. We know what potential impacts are. Can we react fast enough? Should we react? At what pace should we react? Do we have the partners to react with? It caused enormous devastation. You've all seen the television and replays, and it shut down the 3 hospitals for months. It caused billions of dollars of damage and a $60 billion investment from the federal government in the northeastern region. This is the basement of Langone Medical Center. But the coastal storm threat to New York has been known for several decades, and it's been refined. We have these maps, we've been planning, we've been thinking about the coastal storm threat. This is lower Manhattan, and the dark-colored areas indicate Zone A. Zone A is a risky area to be in, and that's where these 3 hospitals are. They're all within 11 blocks of each other, and they're all in Zone A. By the way, this is Bellevue Hospital 100 years ago. Bellevue Hospital had piers to deliver patients to it and to be supplied. All of the land that these hospitals are built on is landfill from the excavation of the Empire State Building and the subway system on the east side. So the 3 hospitals exist within an 11-block north-south radius we call Bedpan Alley. One is the University Hospital, Langone NYU Medical Center, an 800-bed, internationally known medical facility. Hospital several blocks south is the oldest hospital in the United States. It's Bellevue Hospital. It's celebrated last year its 275th year. It has 100 prison beds for patients from Rikers Island. It has a 350-bed psychiatric patient for triple diagnosed, very sick patients, and has a general med-surg hospital of about 450 beds. It sees 1 million patients a year in its outpatient clinics, and it's part of the largest public hospital system in the United States that sees 5 million patients a year. A few blocks south of Bellevue is the VA hospital, part of the federal government system. So Sandy was coming along, and the Department of Health decided that it was going to allow the hospitals in New York City to do what they thought was most appropriate when the hurricane hit. The VA, we found out, evacuated their patients several days before the storm hit, because when we looked down the block, their lights were out, and they had evacuated all their patients into their sister facilities in VISN number 5 in the metropolitan area. Bellevue Hospital decided to shelter in place. It had 800 beds completely filled to capacity, the 100 prisoners, full maternity suite, and it sheltered right through the storm. And when the transformer blew on the Monday, after all the subways were shut down, it was left without any power, and an emerging disaster, potential disaster, was evolving very rapidly. The hospital a couple of blocks to the north was Langone Medical Center, decanted 200 patients out and decided it would shelter in place. So the local context for these facilities is very, very difficult. The hospital hierarchies are completely different. They're all in completely different systems. The competition between facilities in New York, there are about 70 hospitals in the greater metropolitan area, is extraordinary. The political environment is very, very complicated. The leadership issues are very different, how people become leaders in the different facilities. But I want to focus a little bit on the history. What was the context? What is this context that everybody was dealing with? Well, for emergency management, New York City is still living under the umbrella of 9/11. These are the pictures of victims from 9/11 that were outside of Bellevue. It's still, emergency management is an anti-terrorism conversation. It takes up about 20% of a medical director's time. The other big event, the mega event from storm management, was Katrina. Katrina changed the entire concept of the hospital as a safe place to go in a disaster, in a storm disaster, to the hospital as victim. There's a book that just came out by Sherry Fink, who's a physician journalist, called 5 Days at Memorial, detailing the situation at Memorial Hospital in New Orleans during Katrina. She wrote about it won a Pulitzer Prize for that in the New York Times Magazine section a few years ago. It's an exquisite book. So emergency management completely got Katrina. It's not clear that how dissemination happens about these catastrophic events and what is learned by organizationals. What's organizational uptake about these disasters and what's known about them? But even more important from the point of view of the local context in New York City was Hurricane Irene. Hurricane Irene occurred a year before Sandy, August of 11. It was a big, big storm. The Department of Health evacuated all the hospitals in Zone A. Nothing happened. Lesson learned from Irene was a profound lesson, much more than from Katrina. So the organizational risk variables that are really important here, that all of these CEOs and executive teams were worried about, is the lost income, the reputation of the facility. One very interesting issue, there's no moral hazard cost to your facility during one of these events. It's taken off the table. If you remember, during Sandy, it was during the presidential campaign. And a lot of the payback into the New York region with the politics of the situation was a $60 billion check to rebuild the area. And a lot of the conversations were, it won't happen, nothing happened during Irene, it will happen, and patient and staff harm. There are a couple of meta themes that are sort of overviews larger, bigger issues that are latent but played a very, very significant role in how these issues are conceptualized. I just want to spend a couple of minutes on those. One is the whole issue of scientific uncertainty. We're talking about weather events. And the other is organizational decision making. How organizations decide when the risk level to them is such that they actually have to make a decision. If you remember the Obama presidential campaign and Romney, there was not one discussion during the entire campaign about global warming. It simply was a political third rail issue. It could not be discussed. Now, this isn't meant to be a political conversation, right or wrong, that it should have been discussed or not, but it could not be discussed because of the politics. Global warming and what's happening with Sandy and with the other hurricanes are completely interrelated. This book by Naomi Oreskes, who's a very prominent science historian at University of California, San Diego, talks about the merchants of doubt. And the merchants of doubt are organizations that have been created over the last 45 years that look at how science leaves a window of opportunity where there's some uncertainty. And all of you who work in science or work in medicine know nothing is ever 100%. There's always a gap. And the gaps have been exploited by different organizations. And this is called the tobacco strategy. So there have been created organizations throughout the country called AstroTurf organizations who hire very reputable scientists frequently and then exploit the fact that there is not 100% certainty and cast doubt over scientifically proven ideas such as global warming. The tobacco strategy was started about 45 years ago, and if you remember, there was enormous investment by the tobacco companies to prove that tobacco did not cause cancer, and then evolved into a variety of other organizations where there was a need to change the regulation of commercial products and exploited the same strategy, frequently with the same players, the same law firms, and the same public relations companies. It is extremely potent, it is extremely difficult to fight, and it is sort of a background factor that exists, one of many background factors that exists in the decision-making process for healthcare. The other one, and this came up earlier, and this is a very important one, this is the challenger. And John mentioned the O-ring issue. And I've thought about this. I'm a patient safety officer as well as in my hospital. Where are our O-rings? The O-rings were known to be vulnerable at cold weather. The launch of the Challenger was going to happen in freezing weather. There was frantic phone calls from Morton Thiokol, the company that made the O-rings, to abort the launch decision. The launch decision was not aborted. What were the reasons why extremely intelligent, highly motivated engineers, thousands of them, coming up to a small committee, would go ahead with a launch? This is just a parable of many, many decisions that are made in organizations when all the information says, we better not do this, we better be cautious, we shouldn't go ahead with this. And there are many reasons why it does happen. One of them is called this concept, which came out of the Challenger launch, was called the normalization of deviance. Meaning, if you're always driving over the speed limit, and medicine always drives over the speed limit, emergency rooms are always backed up to the gills. There's always patients to be seen during lunch. There's always things happening. There are always breakdowns. There are always production issues. They become normalized. It becomes part of the way we do business. It's okay if you drive 80 miles an hour. There are other ones. The amount of risk you're able to take. Another very important one is that medicine has been extremely focused on medical content and has been very slow to uptake on other kinds of knowledge. I use improvement knowledge here as just one example. But part of the reason why we have silos is that the integration of other policies from other areas requires expert knowledge from other expert groups, such as engineers, for example. And there's been very slow uptake in medicine to do that. Some for good reasons, and some for not such good reasons. And there are some other issues here. But it boils down to, again, what's the proper role of the hospital industry and society, given all the information we've had so far about what is health and how is the healthcare delivery system related to health. In summary, this is the way I see it. The hospital is a social instrument, one of many social instruments. It has to be involved with the social determinants of health. It has to do all the things that we heard about from our two previous speakers, intimately. It has to be under the wing and part of a much larger, broader approach to dealing with these very difficult social issues. We have widening inequalities in society. We have globalization with many unanswered questions. So it cannot avoid these issues. Healthcare leaders, there are about 6,000 hospitals in the United States. Healthcare leadership, and I'm talking about the deans of the medical schools, the leaders in society, have got to intimately be involved with the social determinants of health and their role. The neighborhoods and geographic variations you've seen expressed very, very well. This goes back, I've got to tell you a funny story. This goes back into the 1930s. There was a study in England about appendicitis. And in different clinical area, different regions of the area, all the kids at a certain age, tonsillectomies, excuse me, all the kids had tonsillectomies. And then one year there were no tonsillectomies. And this was published in The Lancet in the 1930s. The surgeon in that particular area had died. The idea was if you had tonsils, they had to come out. And by the way, this same story led Jack Wenberg, who's run the Dartmouth Health Atlas and the Dartmouth Delivery System Innovation Community, to really sparked all of his work over the last 35 years, which is all about the variations in healthcare that exist throughout the United States, the zip code variations. Mental illness is a very important one. The Adverse Childhood Experience, or ACE studies that came out of Kaiser Foundation over 20 years ago by Andretti and colleagues. The training issues, the implications for medical schools and training, for research, the political, social, economic effects, et cetera. And then the ultimate question, does more healthcare equal more health? In summary, really, then it's health has to be in all policies. As David said at the beginning, showing from the Fed point of view, there are enormous, very exciting efforts that are happening in that area. But bringing all the pieces together, de-siloing, defragging the system, is one of the most important things that transformation has to address. What's very interesting to me about getting back to Sandy is the narratives about Sandy, about why we had to shelter in place, about why we couldn't evacuate, about why we did evacuate. The VA left several days before the storm hit, told more about the players than told about the storm and its issues, what their issues were, why they couldn't take the risk or why they could take the risk. These latent factors are critical for us to bring into the light. And as Faulkner said, history is never dead. It is not even past. Thank you very much.
Great to see you. A couple quick questions before we go. You have, among your early medical experiences, direct knowledge of house calls and what they were all about. You described a story of passing out prescriptions for food in Haiti. It seems to me if you're doing house calls as a doctor, you're in a position to know what the dietary habits are of an individual without interrogating them. A house call is an amazing window. What's your first experience with them and why did they go away?
Well, my first experience with house calls was with my father, who was an internist in the Bronx at Montefiore Hospital, and he took me when I was a kid to go see his patients. So house calls
That would be like illegal today, right?
no, actually, house calls are coming back.
But taking someone who's a stranger to go into, yeah, that would be.
Correct.
Yeah, okay.
Correct. That part.
Right.
But house calls are actually coming back as hospitals are having to pay penalties for readmissions and bringing people back into the hospital multiple times. They're looking at other ways to treat patients in the home and visiting nurse associations, et cetera. But the next level up would be physician's assistants, nurse practitioners, and then physicians.
And it suddenly opens up a whole range of behavioral, community health-based data that hospitals can't see from behind the sort of admissions window, right?
John, I've been a doctor for 33 years. I started making house calls again about 3 years ago, and you learn probably 10 to 20% about what's going on with a patient in the office, and it leaves begging the other 75%.
Is that a little hard in New York? I mean, I lived in New York for so long. I mean, if somebody came to my door, hi, I'm a doctor, I'd just like to ask you some questions, I might call the police. That's just so out of the realm of possibility. People are like embracing this.
The reason is New York City has an enormous number of homebound patients for a variety of different reasons. Elderly, multiple sclerosis, a whole bunch of different issues. Mental illness, they're afraid to go out, et cetera. So there are actually businesses growing in the city tremendously to deal with this issue. They simply can't go to see a physician. So what they end up doing is calling 911 and ending up in the local hospital.
Dr. Manheimer, thanks so much.
Thank you.